With Heart Rhythm TV from Denver, Colorado. I'm Dan Alyesh here with an HRS scientific session teaser episode. And I'm very happy to be joined today by my good friend, Dr. Amneet Sandhu. Welcome. He's of the University of Colorado as well as Denver, VA.
Dan, thanks so much for having me on. Happy to join you in this session and to kind of get ready for HRS.
So what the viewers of Heart Rhythm TV do not know is that Neet and I have about a 20-year history. We go back to medical school in our early 20s. So I'm hoping to dig down into that long history to maybe add a little bit of humor or entertainment value to this episode. So sometimes I'll do it successfully too. So we'll start off with a very important first question. So Neet, can you tell us for the audience, how you defeated in a game of pickup basketball a taller and seemingly more athletic classmate of yours, namely me? And if you don't remember, I do have an image of that game.
In this game, I'm wearing kind of a nondescript green jersey.
Well, I mean, just, don't explain yourself. Just admit that you cheated. Okay.
And Dan played for the LA Lakers.
I mean, clearly, that I definitely photoshopped a face for radio picture for me. You look great. But now that we've settled the fact that you cheated and I actually won by default, we'll move on to the actual episode. So, Neet, you are presenting a number of things at this year's scientific session. Congratulations. The first topic I want to discuss, and this is your image here, is your work with biophysics and understanding the transfer of energy and lesions to the posterior wall and the esophagus. So can you tell us all what we're looking at and also kind of some of the salient points of what you learned from this study?
Happy to. I think what you're showing here, Dan, is something that we created in collaboration with the bioengineering group at the University of Colorado. And just to back up one step, I got interested in this by my mentors that, taught me EP. And at that time, we were doing lots of kind of heterogeneity. There was a lot of heterogeneity around catheter ablation of the posterior left atrium. And I think we all have our preferred strategies, and there's multiple developing strategies around what to do with regards to the left atrium ablation in the left atrium, particularly the posterior wall. And broadly, I felt we didn't really have a great understanding of energy transfer period, meaning what happens with regards to ablating on the posterior wall and depth of ablation, transfer of temperature across that left atrium into juxtaposed organs. If you have a single point thermistor measuring this, what's the drop off as your ablation catheter moves away from that single point thermistor? With kind of novel tools to mitigate this risk, how do we understand their efficacy? So in short, I went to the bioengineers. They had a pitch session at the University of Colorado and met some great folks, proposed studying this broadly, and was connected to folks like Blair Holman and Steve Lammers that I've been working with. And we developed kind of a garage back of the envelope version of this and worked through it for several months and then put this apparatus together. So here we're showing in panel A Derlin box. This is a 3D Derlin box that houses a porcine esophagus and posterior wall of the left atrium. You can see that suspended with those two toothpicks. We then have like a simple pump to pump 4.5 liters per minute of normal saline. We can vary the impedance by introducing some ionic content to that normal saline to mimic the general impedances that we see as we ablate on the posterior wall. Mm-hmm. We've got a thermistor array that the arrows are pointing to, and that thermistor array is positioned in the back of the left atrium the interstitial space in between the atrium and the esophagus, the anterior wall of the esophagus, and then we've got another set of thermistors within the lumen of the esophagus. We've got a grounding wire so we can complete our ablation circuit, and we've got a sous vide, so just a simple way to get the temperature of the circulated saline to body temperature. And this isn't meant to be perfect, but it is meant to mimic conditions that we see in the heart in an ex vivo fashion. And what we've done is with this apparatus, try and answer some simple questions, the one that I was alluding to earlier. What's the lag time between when we see a temperature rise with typically a single point thermistor that we use in the esophagus, or other mechanisms, the Circa S probe, you name it, other ways to measure temperature if that's routinely done in someone's lab. What is the lag time between temperature rises in the interstitium, anterior wall of the esophagus, and what you're seeing clinically? How does distance matter? Meaning your probe is in one place, you're ablating at a different place. How does that relate to that temperature rise? How does it change with high power, short duration, for example, versus standard?
That's an important question. I mean, some of these alternative ways of ablating, high power, short duration, however you define that, or changing out the irrigation on your ablation catheter. What did you learn with this model with regards to those technologies?
Yeah, no, that's what without kind of giving too much away. I want Blair to be able to represent this data at HRS. Okay. We learned quite a bit with regards to those three parameters: time, lag, and type of ablation. And that's the crux of some of the things that we'll be presenting. But I can tell you that there are differences. With high power, short duration, you do see differences relative to standard ablation techniques, both at the anterior wall of the esophagus and the lumen. And both of those techniques, the temperature, as you can imagine, at the anterior wall is significantly higher than what we measure within the lumen. So it's just a way for, I think, the community, for EPs and folks that deal with electrophysiology to know things that we probably thought were true, which are, we're seeing results from probes that we use that likely don't reflect what's happening in that space between the ablation catheter and the probe. And through this method, this is the first step, we can develop hopefully more sophisticated ways to get accurate measurements of these things.
Well, thank you. I think that you're leaving a lot to be shared at the scientific session. That's good. Some people talk about an esophageal probe as a false sense of security. I'm not sure what to make of that. In my practice, I monitor the esophageal probe with either ice and tying some sort of mapping or quadrupolar catheter to it, and really trying to triangulate or actually have the tip very close to my ablation catheter. The importance of distance, as you alluded to. If you are able to share, to what degree is that very important?
Yeah, that's a great question. I think ways to facilitate movement of the probe are important. That we found to be an important factor, where if the probe is in one place, even a fairly close place, a centimeter away, for example, the drop off in what you're seeing at that spot relative to where you're ablating is fairly substantial.
Wow.
So with regards to getting data that we trust, which is the intent of having a probe there in the first place, it makes sense to be able to position that probe in relation to where your ablation catheter is. And that can be tricky. I mean, I think efficiency is important in EP in 2022, and it perhaps is impractical to do that, but there are ways to do it in a more facile way, like the one you mentioned, where you put a quad or you tie a quad to it so you can adjust it quickly. But to answer the question of does it matter, we found that it does, and we'll talk and we'll share how much does it matter? Like how fast does it drop as you move away from the thermistor that's closest to the ablation catheter?
Well, fantastic work. I think we'll move on to, another topic, which I think a ton of yield for the practicing electrophysiologist, for those that practice in a TAVR center, dealing with pacemakers post-TAVR, dealing with risk stratification for who needs a pacemaker post-TAVR, it can be a real challenge. And so you developed a score, which I think you'll be sharing. And so would you comment a bit on, how you derived it, maybe what you learned while not giving too much away, I guess, for the scientific session?
Happy to. TAVR, as we all know, has disrupted the way that we treat aortic valve disease, and in some to most instances, the preferred way to treat aortic valve disease, in particular if it's isolated aortic valve disease. So with the litany of data that we know about that have related TAVR to conduction system disease, the fact that the valves that we implant are juxtaposed to the conduction system, the AV node, the His, we're looking to develop something that's simple to use, that we can use pre-procedurally. And folks have done great work with regards to developing scores or developing data that is related to development of conduction system disease. But it seems the utility of that was either intra-procedurally or post-procedurally. So the goal here was, can we develop something that's relatively straightforward that teams can use beforehand and counsel the patient, perhaps involve their EP colleagues if they're being seen in a valve clinic, and discuss what the risk of a pacemaker might be. So we took folks that had undergone TAVR here at the University of Colorado and split them up into a training cohort and a validation cohort. And this was all, led by Chris Barrett and a bunch of other folks here. And we found that these variables, pure interval, right bundle branch block, valve and valve procedure, which is defined as implantation of a TAVR valve with a bioprosthetic valve or another TAVR valve in place, myocardial infarction and self-expanding valve impact your risk of TAVR. I think a lot of us know that right bundle branch block is a powerful one. You're impacting the left conduction system with introduction of these valves. So if you have pre-existing right bundle branch disease, that could influence the rate of high-grade block. And these other variables, they discriminate in addition to right bundle branch block. So, we think about this a lot, other folks might not, and hopefully this is a tool that people can use quickly, readily to say, hey, you're likely not at risk, and I think that is helpful, or you might be at additional risk, and I think that's helpful too, and help to set expectations with patients to arrange colleagues for potential intervention.
So neat. Looking at your score here, I can't help but understanding the impact on the number. It looks to me like valve and valve is somewhat of a reassuring procedure with a negative addition, and I can understand why that is intuitively. Myocardial infarction decreases your score a bit. Can you comment a bit about your thoughts on that?
Yeah, it's a good question. There are data to show that valve and valve is protective with regards to development of advanced conduction system disease. MI bore out as a variable that is modestly protective, and we can discuss that. We can hypothesize as to why that might be. Perhaps it relates to collateralization of blood flow, of the fact that you've got ischemic preconditioning to regions that might affect the or blood flow to the conduction system. But in truth, I don't think we know. I think that this is a variable that we've seen to be protective, but the mechanisms as to why are hypotheses rather than those that are borne out in further kind of more rigorous work. But it's a good point. I think the future of this is prospective study. It's looking at this in application to those that are going to get TAVRs in the future. TAVR is a game changer, and it in use for low, moderate, and high risk aortic valve disease. So I think we're going to see, we've seen substantial growth of TAVR, and we'll continue to see substantial growth with use in TAVR. So this, provides an opportunity for us to kind of refine this score, to apply it to prospectively to other data from both other sites, and then try and gauge what it means. Like, does the prime score help you determine how much someone will pace? Should you think about, in some instances, placing a left bundle or a CS lead in someone that you might think, boy, they're going to pace a bunch? So it, it's exciting. I think the future of.
I mean, there's a lot to learn here, because there's the who needs a pacemaker, and then there's the sudden cardiac death risk associated in a certain cohort, that leave with left bundles, and we believe that potentially, pacemaker implant mitigates that risk, but that could be in itself another question. So, whatever tools we can develop to try to improve this practice, because it can be rather challenging. So
it can be tricky, and I agree with you. I think it's evolving. It's exciting. It's a collaborative work between the interventional teams and the electrophysiology teams that are practicing at TAVR sites. And TAVR is becoming more and more a procedure that's available, not just at tertiary care centers, but at centers that are may not have some of these other capabilities, and that allows them to make sure that the right resources are around.
Absolutely. And then I want to kind of conclude here with, I know you're doing another session. I think it's on the involving patients in the patient experience of ablation. And, I just think that's so important. Your patient's experience with their ablation, at least in my experience, and sometimes it's very much determining of whether they believe you're a good or not good doctor, and their experience with the procedure. So will you comment a bit on that session, and maybe with some teasers for why we should be excited to go?
You bet. I think this is a exciting session, because it's something that those that practice clinical EP, we know that it's really important with regards to engaging patients in the decisions that we're making together. So this session is out of the quality improvement initiative, and it relates to the patient experiences, patient clinician experiences around atrial fibrillation, particularly atrial fibrillation ablation. So the format is, Anil Gehi and I kind of helped organize this, and the format is to have a patient representative that has gone through atrial fibrillation, describe her experiences of what worked, what didn't work, what helped with regards to feeling connected to the whole process. And to help, as part of that, to help set up the stage for, well, what are the social determinants that are important when considering AFib ablation, communicating AFib ablation to patients. To go through some techniques that have been developed that help facilitate this, decision-making processes that fit within a busy clinical workflow that could be employed in clinics to help engage patients with regards to the whole process of antiarrhythmic therapy, perhaps weight loss, treatment of sleep apnea, and consideration of catheter ablation, to help patients realize and engage with the process of the need for repeat ablations if they're necessary, so on and so forth. And I think that, in my opinion and experience, that leads to satisfaction, both from the patient and provider standpoint, that people are on the same page and you've approached this together. Lastly, I think the there's an important part of this session that is geared towards diversity, equity, inclusion. So we've got folks that are going to comment on how to communicate this to all types of people and to make sure that the message is heard and reasonable and makes sense and is inclusive. So I think it'll be an important session, hopefully in effort to provide tools that we can all use to help us and help patients in a busy clinical format.
Oh, wonderful. I think, viewing your patient as a partner in the process and finding a way to build that relationship can yield huge dividends in managing AFib, whether it's ablation, whether it's lifestyle, all the above are important. Well, thank you very much, Dr. Sandhu. We look forward to your sessions and all this great work you're doing at HRS. Viewers of Heart Rhythm TV, this is your teaser, and tune in from San Francisco to learn more.
Dan, thanks so much for having me. Really fun to chat, and I can assure you that that picture is inaccurate because I can't jump that high at all.
I know. Exactly.